Hi everybody, Dr. Becker. We're back with chapter 50, and in this chapter we start diving into women's health. There's two different kind of sections in terms of regarding women's health, and one of them is the contraceptive or non-contraceptive chapter. So they start off with the non-contraceptive applications of women's health, basically talking about estrogens and progestins. So in this chapter, we start with the non-contraceptive, and then in chapter 51, we jump into the birth control things. So to review, though, that'll apply to both chapters 50 and 51, is to discuss, again, what the hormones of estrogen and progestin do and how they work physiologically in the body, so that we have a good understanding of when things go awry, how we can treat pharmacologically. So they start about talking in your book about the estrogens and progestin and physiologically how they work in the body. Together, they have a fancy name of progestogens. I've never called them that a day in my life. I've always referred to them as estrogens and progestins separately. They are hormones that do a multitude of functions within the body. They also do have effects outside of the female reproductive system. In this chapter, again, we're focusing on female over male. In females, estrogen and progestin both promote female maturation and help regulate the ongoing activity of your female reproductive organs. So in other words, you have to have adequate levels of estrogen in order to mature as a female. Estrogen and progesterone both also affect our bone mineralization and our lipid metabolism. When we talk about endogenous estrogen, the biggest hormone that we produce is estradiol. There are some estrogen in the peripheries that act and convert into some other hormones. For the most part, when we're talking about estrogen, we're probably really referring to estradiol. The principal endogenous progestinal hormone is progesterone, and both of those are produced by the ovaries. It's important to remember, too, that during pregnancy, your placenta produces a large amount of estrogen and progesterone as well. There is a small amount of your estrogen and progestin that are produced in your peripheral tissues, but the far majority is going to be happening in the ovaries and then during pregnancy also in the placenta. In order to really understand women's health, it's important that we understand our menstrual cycle. This is something that I never have memorized off the top of my head because I've never really worked solidly in women's health. So this is something I review quite frequently as well. Because it comes in one ear and I can't retain it and goes out the other. So this is a good review for me as well to discuss the menstrual cycle. We have both anatomic and hormonal changes that are occurring during a female's menstrual cycle. And if we jump in here to figure 50.1, we can kind of break this down a little bit. So multiple things are happening simultaneously here. This chart here is referring to the days. So it starts at 0, and this is a 28-day menstrual cycle. Some women, as you know, can go 30, 32, 34 days, anywhere in between. So this graph is showing you simultaneously as the days progress through the cycle, what the ovaries are doing, what the endometrium is doing, what our ovarian hormones are doing, and what our pituitary gonadotropins are doing. So the menstrual cycle is really this coordination of events between the hormones and these organs in the female body. So in our ovary, they start with first. So this is day 0, so your menses has just started. And this is what starts the follicular phase. So follicular phase is at day 0. So the sequence begins in the ovaries at day 0, where several ovarian follicles will ripen, and one of the follicles ruptures, causing ovulation. The ruptured follicle evolves into the corpus luteum, and if fertilization does not occur, the corpus luteum will atrophy. So as these are taking place in the ovary, the steps of the ovulation here, simultaneously in the endometrium, hopefully the lining of the uterus then is trying to prepare for what they refer to as nidation, which is implantation of a fertilized corpus luteum, right? So at day 0, the female starts her menses and she sheds the lining of the endometrium during the follicular phase here. After ovulation, the uterus continues its preparation by increasing the secretory activity here. As it's preparing in here to receive a fertilized egg. And if that doesn't happen, then we get to here, which is actually the start of here, and then menses would occur. So menses occurs when there is a failure of implantation in this thickened, ripened endometrium. Okay, so simultaneously as the ovary is producing this cycle and the endometrium is doing this with the lining of the uterus, we have the follicular phase. After ovulation, then you begin into the luteal phase, which reflects in what is happening in our ovarian hormones. So the changes that occur during the cycle are brought about by the influence of these hormones of estrogen and progesterone that are produced by the ovaries. So during the first half of the cycle, the estrogens are secreted by the maturing ovarian follicle. So, females shed the lining of the uterus here. Estrogen kind of starts to peak up at this point in the proliferative phase of the follicular cycle, which drives then in what causes the maturing of the ovum and then causes ovulation here. Right before ovulation is going to occur, and right before you start the luteal phase and the secretory phase of the endometrium, the ovary has a sudden drastic intake of progesterone in preparation for receiving a fertilized egg. So this is mid-cycle, and at mid-cycle, the ovarian follicle ruptures, right, which causes ovulation and makes into the corpus luteum. Estrogens and progesterones are produced by the newly formed corpus luteum, so now that's what's secreting it there. The hormones maintain the endometrium in this hypertrophied state, and at the end of the cycle, that corpus luteum atrophies, causing a sharp decline now, as we can see here, of the estrogen and progesterone. In response to the diminished supply of these hormones, the endometrium is signaled to break down, and you start your menses. The menses starts here, and the cycle resumes. Okay. So also at the same time, there's another component of what is happening, and this is in our pituitary gland and the production of our pituitary gonadotropins. So we have 2 of these hormones from the pituitary, and this is the follicle stimulating hormone and the luteinizing hormone, so FSH and LH. This is precisely timed alterations in the secretion of these hormones, and that precisely timed alteration is what's responsible for coordinating the structural and secretory changes that occur throughout the cycle. During the first half of the cycle, which is follicular phase, the follicle-stimulating hormone acts on the developing ovarian follicles, causing them to mature and secrete estrogens. So the pituitary secretes our FSH, which then in turn acts on the ovaries and helps produce the maturing follicle, which then changes the level of estrogen that's going to be secreted there. The resultant rise in the estrogen level will exert a negative feedback cycle on the pituitary gland. So the pituitary is going to say, oh, we got enough surge of estrogen, and it's going to suppress the FSH further. At mid-cycle, all of a sudden, right, so it goes up a little bit here, and it realizes at this point, see that we have enough. So the pituitary shuts off, and your FSH goes back down. At this midpoint in the cycle, though, right before that, as you're about to transition into the luteal phase with ovulation, the luteinizing hormone rises abruptly. You can see this sharp intake here. This surge causes the dominant follicle to swell, burst, and release its ovum. After ovulation, the ruptured follicle becomes a corpus luteum, and under the influence of the LH, begins to secrete progesterone, right? So it's this spike in our LH that causes our ovaries to respond with a spike in progesterone, preparing to receive a fertilized egg. The spike happens very quickly, right at the beginning of the luteal phase, and then the LH drops back off to very low. So this is the example here of the female menstrual cycle, and it's important really to understand this because we want to understand what Later, when we talk about contraceptive, we want to talk about how we interrupt this process to prevent pregnancy. So we have to understand what the process is to begin with. Okay. So to recap, our estrogens and our progestins have many actions. They promote our maturation. They help regulate reproductive organs. They will affect our bone mineralization, our lipid metabolism. Our principal endogenous estrogen is estradiol, and our principal progestin is progesterone. Okay. So what happens in the body when we have estrogen, and how are we using it within the body? So we want to talk about the physiologic effects and the pharmacologic effects of giving estrogen, but let's really understand what's happening when we have normal amounts of estrogen cycling. So what we're really referring to at this stage when I say normal amounts is a premenopausal female. So someone who's someone who has achieved maturity, so they've started their menses, and then they have not hit menopause. So women in that category, the normal physiologic process of our estrogen, what is it doing? Okay, so remember that during the follicular phase, the estrogens are synthesized by the ovarian follicles, and then during the luteal phase, the estrogens are synthesized by the corpus luteum. And again, we produce mainly estradiol from the ovaries. In the periphery, though, this is what I was talking about before, some of the estradiol secreted by the ovaries is converted into estrone or estriol. So there are different types of estrogen hormone, but primarily we deal with estradiol. Estrogens are eliminated by hepatic metabolism and urinary excretion. Okay, so remember that during pregnancy, the placenta is what starts to produce a large amount of estrogen. In men, just as a side note, there's always a small amount of testosterone that is converted into estradiol and estrone by the testes, which is why sometimes I think people forget that men do produce a small amount of estrogen. So physiologically, what's the mechanism of action when we have our own endogenous, or if we were to give exogenous estrogen? So estrogen acts very similarly to the other steroidal hormones, which includes testosterone or cortisol. Estrogen acts primarily through receptors in the cell nucleus and not on the cell surface, but there are some that work on the cell surface. It's either or. So to produce its effect, oftentimes estrogen has to diffuse into the cells and migrate to the nucleus. That is where it binds with the estrogen receptor. Some of it, though, does have estrogen receptors on the surface. Once the estrogen complex has formed, so that means that the estrogen has bound itself to the estrogen receptor, then that's what we're talking about. That's how it becomes physiologically active. It's important to note, like I said, that not all of the receptors are found in the nucleus. Some are on the cell membrane. Activating these surface receptors is what produces a rapid response, more rapid than if the estrogen has to work within the cell, if the receptor is buried within the cell nucleus. There, to get into the detail of it, we actually have two types of estrogen receptors, alpha and beta. Alpha is highly expressed in the vagina, uterus, ovaries, mammaries, vascular epithelium, and our hypothalamus. The beta is expressed in ovaries and prostate, and less extent we have beta expressed in the lungs, brain, bones, and blood vessels. And then some of these actually have both types of estrogen receptors. So if we were really to dive into which receptor is located where, you could get into some big detail. I just want you guys to understand that in reading or in the future, you may hear like estrogen receptor alpha or estrogen receptor beta. There's two different types. So mainly physiologically, our estrogen is going to affect our primary and secondary sex characteristics of being female. So one of the first things it's going to do when we have estrogen at the levels in our body is that it's going to develop and then maintain our female reproductive organs, and then our secondary sexual characteristics as females. So the hormones that are required for growth and maturation of the uterus, the vagina, fallopian tubes, and the breasts are the estrogens. Estrogens also is what causes direct pigmentation of your nipples or genitalia. Estrogens have a profound influence on these physiologic processes. Anything related to reproduction, there's going to be mainly the driving force is going to be estrogen. So let's break that down a second. During the follicular phase of the menstrual cycle, estrogens promote, at that time, those are working in the body by promoting ductal growth in the breast, which is why we know that there's estrogen receptors in the breast tissue. So if someone has ER positive breast cancer or ER negative breast cancer, that's where we are getting that estrogen in the breast from. and that is working during the follicular phase. Also in the follicular phase, we have thickening and cornification of the vaginal epithelium. So the vagina tissue is maintained during the follicular phase with estrogen. Then the proliferation of the uterine epithelium is obviously controlled by estrogen as well. And then the estrogen is also responsible for copious secretion of thickened mucus from the endocervical glands. And so you have to have enough circulating estrogen to have those effects taking place. Estrogens also will increase vaginal acidity by promoting local deposition of glycogen. So, and that in turn works on the lactobacilli and it produces lactic acid, etc. So that is why also women are at a higher risk for urinary tract infections because of the change in acidity. At the end of the menstrual cycle, a decline in the estrogen then brings on the menstruation. But it is the fall in the progesterone at the end of the cycle that it actually causes the breakdown of the endometrium and causes menstrual bleeding. And that's an important distinction here because when we're going to try to manipulate and prevent pregnancy, when we start to alter the menstrual cycle, one of the hormones we do use is progesterone. So you have to have a decreasing level of progesterone is what's actually going to trigger your menses. Or female menses. So if someone wants to prevent having a menstrual cycle for some reason, well, if we were to start adjusting their progesterone level, they would skip their menstrual cycle because you have to have that decline in order to trigger the endometrium to shed the lining. And then after your menses is done, during these phases here, your estrogen then promotes endometrial restoration and thickening again. Endogenous estrogen, so our estrogen that is naturally made, can also affect non-reproductive tissues. So it's also important for bone health, cardiovascular health, blood health, and our neural or our cognitive health, the CNS. The other interesting thing that estrogens do is they do actually play an important role in glucose homeostasis. So let's break this down kind of system by system for these other these other actions of estrogen. So first of all, in the bone, right? So if I were to say, what is the physiologic process of estrogen in a premenopausal female, and how does it affect bone? We would say that it's a positive effect on our bone. So under normal circumstances with a normal, quote unquote, female of that age, the bone is just like everybody is undergoing continuous remodeling. So remember that the bone mineral is resorbed and then deposited in equal amounts. So the effects of estrogen in the female body on this process is to block bone resorption and kind of promote good bone strength. During puberty, when we start to develop our growing influence of estrogen, the long bones are growing rapidly because of the influence of growth hormones, adrenal androgens, and low levels of we're beginning to produce ovarian estrogen. And when the estrogen levels grow high enough, and we develop in puberty fully, then that is what promotes the epiphyseal closure and brings your linear growth to a stop. So in the female body, estrogens work positively and they have a positive effect on the bone. They affect our bone growth in early, the transition from childhood into puberty, and then they help maintain good, healthy bones during this stage when you have enough estrogen. Next one, cardiovascular effects. So if we were to say, what's the physiological effect of estrogen in a premenopausal female related to cardiovascular? We would say that it's cardioprotective because we know that cardiovascular disease is less common in premenopausal women compared to postmenopausal women. Well, obviously we know probably a 30-year-old is probably less at risk for heart disease or stroke than a 60-year-old just based on age. But part of that actually, when you refer to females, is because of the change in estrogen. So estrogen receptors in the vascular smooth muscle respond to activation by decreasing vasoconstriction, so they allow good blood flow. And so the estrogen receptors in the endothelium result in the production of nitric oxide, which results in vasodilation and increased perfusion. Estrogens also decrease atherosclerosis through favorable effects on our cholesterol. So estrogen is a positive cardiovascular protective effect. And it affects our cholesterol because the LDLs will be reduced and our HDL can be improved based on how the hormone of estrogen is working. So the next thing is blood coagulation. Estrogen both promotes and suppresses blood coagulation. But the real thing I want you to understand here is that that's also why when someone goes into menopause, we have some of the thromboembolic types of risks as well. Next is the central nervous system. So in the central nervous system, our estrogens have a very neuroprotective effect because the estrogen helps defend the neurons from the effects of oxidative stress and injuries. So again, having the appropriate circulating amount of estrogen physiologically has a CNS protective component to it. Estrogens have a role in our neuronal growth and our repair of the nerve growth factors. Estrogen-induced synaptic changes that are coupled with the estrogen-promoted increases in synaptic serotonin, dopamine, and norepinephrine, and through that process is thought to preserve our cognitive function, enhance and maintain good short-term memory, and helps regulate mood. Cerebral perfusion is also enhanced, again, by that release of the nitric oxide and the resulting vasodilation. So when a female is going to enter into menopause and drop down on the estrogen, that's why we can also see some CNS or kind of neuro effects from menopause. And then the last one is glucose homeostasis. So estrogen plays a vital role in maintaining our glucose levels. So in conditions that lead to insulin resistance due to impaired transport, estrogen has been shown to increase insulin sensitivity to promote glucose uptake. So having enough circulating estrogen helps promote insulin sensitivity. Estrogen is also believed to have a role in insulin secretion and is believed to actually be protective of the pancreatic islet beta cells from certain types of injury. So that is a good thing. This also does play into the role of why women that go through menopause tend to gain weight, is because now we've lost the positive effects of estrogen in our glucose homeostasis. So now we understand physiologically, let me change that here, I just want that to be for this slide, physiologic effects. Okay, so now we move into the idea of menopause, and we understand that menopause means the period of time when a female transitions into no longer having a menstrual cycle, and she's no longer able to reproduce. The age, when you read when does menopause happen, it's between the ages of 45 to 55. And so generally speaking, I say menopause happens about 50, 52. There are women that start to have premenopausal type symptoms. And when you really dive into their levels, maybe at the age of 45 or 46, they're starting to show some premenopausal decline in some of their hormones and their activities. But it's about 50 to 52. First, to really define the premenopause and starting into menopause, what they see is that the menstrual cycle becomes irregular. You may have anovulatory cycles, meaning you don't even ovulate, and then you're going to have potentially periods of amenorrhea alternating with menses. So you may have a cycle where a month goes by and the female does not have menses, and then you'll have an irregular menses, and then you'll have 2 months with no menses, and it can be a very irregular time. Eventually, ovulation and your menstruation cease completely, right? No more. And in order to say you are in menopause, you have to have no vaginal bleeding or any kind of cycle for 1 year. Once you've hit that 1 year, you're menopause has happened officially. And then over time, the actual complete loss of any circulating estrogen from the ovaries for most people declines gradually and variably. So some people, even if they've not had a cycle for a year, they still could have some circulating estrogen from the ovaries until the ovaries completely atrophy and stop producing estrogen. Okay, so if we know that we have many physiological protective effects as females having enough estrogen, it makes sense to assume that once a female goes into menopause, we lose those those protective effects of our estrogen, and now you get symptoms from it, right? So these things make sense. One of the first things is what they call vasomotor symptoms. And so these are the typical hot flashes and night sweats. Over 70% of postmenopausal women are going to get these symptoms, and some of them can even persist for years or a decade, okay? And when we talk about hot flashes or night sweats, these are drenching, serious episodes where you get suddenly very flushed, very hot, very sweaty, and they're very uncomfortable. They can happen in the dead of winter, where all of a sudden you're like in a furnace. And so when you are treating a female who's in a menopausal state or perimenopausal state, those are vasomotor symptoms. Oftentimes, the problem too is that they occur a lot more frequently at night. And so that really causes sleep disruption and sleep disturbances, and part of sleep gets disrupted anyway. And so many women that are in the menopausal state do not sleep well. They have problems with fatigue, irritability, and these vasomotor symptoms. And these can be very detrimental to their quality of life. So this stage in life for some females, not all, but some people really struggle with perimenopausal symptoms, and they really have a decreased quality of life that can lead to increased anxiety or depression. So these are not trivial things for many women. The next thing is, again, we said, remember that the estrogen is so profoundly involved in the female reproductive system. So when you have menopause, there's the genitourinary syndrome of menopause. So all the structures in the body, the urethra, and of all of them, the urethra and the vagina have the highest concentration of estrogen receptors. So those receptors, when they're activated, helps maintain the functional integrity of the urethra and the vaginal epithelium. So when estrogen levels decline during menopause, those structures of the urethra and the vagina go through degenerative changes. That can lead to a constellation of symptoms, and that's mainly from atrophy from the loss of the estrogen. So the atrophy of the urethra causes urge incontinence and urinary frequency. Urethritis and urinary tract infections can also occur. Menopausal women and postmenopausal women are at a much greater risk of having UTI. Atrophy of the vagina epithelia can lead to dryness, which can also then lead to dyspareunia, which is pain with intercourse. Oftentimes at that stage, if people have this syndrome that are female, then they oftentimes need some kind of lubrication or something to address that. And alterations in the vaginal secretions result in decreased acidity, which can allow for the overgrowth of pathogenic bacteria. So you're at more of a risk for vaginal infections. There is a condition called female sexual interest arousal disorder that is different than perimenopause, but unfortunately it also occurs at this stage of life for many women as well. So it is somewhat of a different thing. The mental changes that can come with menopause too come from losing that the neuroprotective effect of estrogen. So they become brain fog, poor memory, increased anxiety and depression, or again, those changes in sleep. And then the next thing, of course, is the bone. So now we've lost that bone protection of estrogen. So when you don't have enough estrogen as a menopausal female, the bone resorption accelerates, and you can lose 12% of your bone density even shortly after menopause. So osteoporosis is of big concern. Remember, osteoporosis is characterized by the bone demineralization and that altered bone architecture, and that leads to reduced bone strength. So compression fractures can happen commonly, and that causes also decreased height of the vertebra, and that's why some women in the postmenopausal period get that kyphosis, or kind of the hump back. And then women in this postmenopausal phase, because of osteoporosis, fractures of the hip and wrist can result from even minimal trauma. Then we said it affects our altered lipid metabolism. So you can start to see increases in your LDL and a decrease in your HDL just from the lack of having circulating estrogen. So when we talk about the clinical pharmacology of estrogen, is when would we give somebody estrogen as a medication or as a pharmacologic intervention? Okay, what are the uses of it? The first and foremost one of estrogen is going to be menopausal hormone therapy, which is commonly referred to as just HT or HRT, which is hormone replacement therapy. And that is the most common non-contraceptive use of estrogen. So when estrogen is used for the purpose of hormone replacement therapy, it is usually accompanied also by the use of progestins. So one of the conditions that people could be on estrogen for could be female hypogonadism. So in childhood into adolescence and trying to have a pubertal transformation, if you don't have enough estrogen because of you can't produce it from the pituitary, then maturation will not take place. So that can be from hypopituitarism or ovarian failure or like Turner syndrome. We're not going to go into great detail about that. Next reason someone may be on estrogen is for treatment of acne. Also, we use estrogen, as we know, in cancer care. So if you have an ER/PR positive breast cancer, estrogen receptor positive breast cancer, you may be on a type of estrogen. We also can use estrogen in cancer for men in prostate cancer. And then people may be on estrogen for gender affirmation therapy. When someone takes estrogen, it has the potential to cause adverse effects. The first concern is always going to be endometrial cancer, breast cancer, and then cardiovascular thromboembolic events. Okay, so those are the big three when you think about why someone should be cautious about taking estrogen. For the endometrial hyperplasia that could lead to cancer, we can often evade that by also prescribing a progestin. Other problem with it is that some people on estrogen will develop gallbladder disease, jaundice, or headaches. Nausea is the most undesired response and very common. Fortunately, it tends to get better with prolonged use of estrogens, but it's also one of the reasons that women can't tolerate to take the estrogen. Estrogens also increase your risk for headaches and especially migraine headaches. It also can cause chloasma, which is that patchy brown kind of patches on the face of discoloration that aren't life-threatening. They won't hurt you, but they can be a significant cause of distress for females to have weird brown splotches on their face. So when you think kind of adverse reactions, the big ones we worry about are going to be the endometrial hyperplasia / endometrial cancer, breast cancer, and then the possibility of cardiovascular thromboembolic events. Common side effects I would call the nausea, but that does tend to get better with time, and then it can worsen or uncover gallbladder disease. And then if you have a history of migraine headaches already, I'm not sure that hormone replacement therapy is something that I would find something that I would want to give somebody because it can really trigger migraines. Okay, the contraindications to take estrogen mainly are if you've had a DVT or PE, or if you've had conditions such as a stroke or MI that occurred secondary to a thromboembolic event. Also, estrogen is not to be given to women who are pregnant, or if you have vaginal bleeding of unknown origin. We don't just want to start giving that estrogen because it could potentially be a cancerous situation. You also have to be careful in patients with a history of liver disease, if they have estrogen-dependent tumors, or if they have breast cancer. That is not being a treatment form of it. So in other words, if someone's had a history of breast cancer and now they are seeking hormone replacement therapy, they should not get estrogens, right? That's a bad idea. There's the possibility that estrogens can interact with drugs. Specifically, they think of anti-diabetic drugs, some thyroid drugs, and then some of the clotting or DOAC type drugs. Next, I want to talk about how estrogen is prepared and how it's available. There's a little nuance here, is that estrogen is available in conjugated and esterified forms. The esterified forms are plant-based. The conjugated estrogens are a natural preparation derived from the urine of pregnant horses. Now again, that's a fascinating fact to me, and if any point in your guys' lives in the future you're out there and you're on like trivia night somewhere and you get that question correctly, message me and let me know. Those are the weird facts that I think are fun to know. But the important thing is that esterified estrogens come from the plants and the conjugated estrogens come from the urine of pregnant horses, and they're synthetically made. So first of all, you can take it orally. It's an option for those medicines. Oftentimes, the estrogens are used transdermally, and there's a couple of reasons for that. When you compare it to oral formulations, transdermal have 4 advantages. 1, the total dose of the estrogen is greatly reduced because the liver is bypassed. So you can put it on and you're only going to get a certain amount. There's less nausea, vomiting, the blood levels fluctuate less, and there's actually a lower risk than for DVT, PE, or stroke. So there is some purpose of why some people feel transdermal is safer than even oral. So there's a couple different medicines in your book that talks about that as a transdermal route. The interesting thing is that it does very much matter which of these drugs you use and what location of your body. So there's one called Estrasorb, which is an emulsion, and that's applied once daily to the top of both thighs and the back of the calves. Then there's a spray called Evamist, and that's applied once daily to the forearm. There's a gel that's called Estrogel or Elestrin, and that's applied once daily to one arm from the shoulder to the wrist or to the thigh. And then we have patches, which are like Alora, Climera, Estroderm, and those are to be applied to the skin of the trunk, but not to the breasts themselves. The transdermal formulations, the rate of absorption can be from 14 to 62 micrograms per 24 hours, depending on the product. So you may wonder, well, why would you give someone who could take a pill a transdermal? There's a couple different reasons. It's the duration of the mechanism of action, how long they last, how the preparation is, but also they think that some of these can be safer and more or better tolerated. The other way that estrogen can often be given to a menopausal or perimenopausal female is intravaginally. So there's estrogens that are administered as inserts, creams, or rings. So the intravaginal rings come as two rings. The S string are only used for local effects. So this is primarily treatment of the vulval and vaginal atrophy associated with menopause. So if that's the woman's biggest complaint, then using a vaginal insert with a ring could be very effective, and you're avoiding, because it just works locally, you're avoiding the risk of the side effects of using, oral hormone replacement therapy. The other ring is called the Fem ring, and that one, though, is used for systemic effects like hot flashes, night flashes, and local effects of the vulval and vaginal atrophy. So the Fem ring is a pretty popular one that a lot of people will use. You can also give it parenterally, which is very, very specific use only, and it's pretty much in heavy uterine bleeding. So that's not something you're typically going to see. The book does go through and give your patient education on like the patch and some of that education that you should read over, because that is what you would be telling your patients in the future. So example, you have to rotate sites. You don't want the same site to be applied day in and day after. Like the emulsifier and the gel and the spray, they give some of those specific directions, like the intravaginal cream should be used at bedtime. The ring can be left in place for 3 months and then it can be replaced with a new ring. It kind of goes through and talks about that. So I think it's worth your read of that. When you're going to be giving someone an estrogen, okay, the purpose of it is you're trying to treat either the symptoms or the structural changes that have been associated with your decreased endogenous estrogen. So I'm talking about estrogen outside of the treatment of cancers. Basic metabolic and kind of basic data is indicated. So we have to know what their baseline heart rate, blood pressure, weight are. Almost always, I would say always really, pregnancy test, no matter what, because we don't want to give that. Thyroid should be tested, and then we want to know what their lipid panel is. Number one, their lipid panel could be at an increased risk for being bad because they're menopausal, but we also want to make sure we have something for comparison too. And then a good gynecologic exam is indicated prior to giving them hormones. They also should have a thorough screening for breast cancer and then a thorough cardiovascular risk assessment. You know, if you're 54 years old, you have really bad symptoms, but you're diabetic, you're obese, your mom and your dad both died in their 40s of heart disease, and you've already had a DVT after your knee replacement. Not sure that estrogen's right for you. Okay, so the risk factors that go into this are important as well. Then while somebody is on the estrogen, you are monitoring their blood pressure, their weight. And then as we're talking months down the road, you should follow the lipid panel, their thyroid, and then they do still need regular breast and pelvic exams as routine per age. Schedule endometrial biopsy for unscheduled bleeding that continues for 6 months. People can spot after you start the estrogen again, but if that persists into 6 months of treatment, then they should have an endometrial biopsy to make sure you're not having endometrial hyperplasia. And then you should evaluate for therapeutic effects. If you're having your females on these medications and you come back for follow-up, and you need to ask, is it working? Because if it's not truly working and it's not something that's improving their quality of life, I don't know that the risk is worth it to be on those medications. The effect, depends on whether it's working, depends on what you were using it for. Are we worried about the vasomotor symptoms or the vaginal atrophy? So that's another thing. If you'd go and you're monitoring their gynecologic exam and the vagina is not moist and pink and healthy appearing, then maybe what they're doing is not working, it's not helping, and maybe they shouldn't be on it because of the risks that it carries. Remember also that menopausal hormone therapy with estrogen alone will increase the risk for endometrial carcinoma. So that is why the progestin, even at a lower amount, helps decrease that risk. All right. Then we go into, next slide, phytoestrogens. So phytoestrogens are the plant-based compounds that have weak estrogenic activity. So there's 3 types. These are isoflavones, lignans, and coumestans. The most commonly used and studied phytoestrogens are the isoflavones, and those are derived from plants such as soybeans or red clover. Phytoestrogens are commonly used by women because it's felt to be a more natural way to manage their symptoms from menopause. There is strong anecdotal support for phytoestrogen therapy. However, randomized controlled trials are just too inconsistent. With that being said, their use is not necessarily discouraged, but we can't say that we had good evidence to encourage it. So it's that very middle of the road statement. And it kind of depends on your provider. Women may be able to find a provider that feels strongly in phytoestrogens and may use them in their routine, and some of them would encourage you not to do it. It's hard to say. Phytoestrogens are not as potent as estradiol, but they can carry the same risks. So that's why, to me, that's kind of hard to say you're just at risk by being on this, but you're not going to get the bang for your buck. But, people do what they do. Women should not use these phytoestrogens if they have a history of thromboembolic events or personal family history of breast, uterine, or ovarian cancer. Okay. The American Association of Clinical Endocrinologists, that society tells and suggests that women preferring to use the phytoestrogens should be encouraged to obtain these ingredients from whole food sources to avoid overdose. So for an example, the book goes in and tells you that, 1 gram of soy is approximately 1.5 milligrams of isoflavones. So they kind of say maybe just have a rich phytoestrogen diet more so than taking over-the-counter medications. But it's out there. People do use them. You're going to see them used in practice for hormone therapy for postmenopausal women that don't have enough endogenous estrogen. Next group of medications is our SERMs. Remember, that's selective estrogen receptor modulators. So these are drugs that activate estrogen receptors in some tissues, but in others block them. So these drugs were developed in an effort to provide the benefits of estrogen. So they wanted to have something that could help protect against osteoporosis, etc., but avoid its drawbacks. So 4 SERMs are available, and this is tamoxifen, tauromorphin, raloxifene, and bezadoxifene. None of these offers all the benefits of estrogen, and none is without a potential bad side effect. So of the SERMs, tamoxifen was the first one to be widely used. So I would create another little section of your notes here for tamoxifen. It blocks estrogen receptors. So by doing that, tamoxifen and its active metabolite endoxifen inhibit cell growth in the breast. So as a result, tamoxifen really is used extensively to prevent or treat breast cancer. The problem with it is that, yes, that's a great thing, but the blocking of the estrogen receptors also then still produces hot flashes. By activating the estrogen receptors, tamoxifen protects against osteoporosis. It can have a favorable impact on the serum lipid levels, but that receptor activation will also increase the risk for endometrial cancer and the thromboembolism. So we talked about tamoxifen in chapter 85, and so it's really only used in the treatment of breast cancer, and it almost always will cause hot flashes. And it still has the potential side effects that are dangerous. Raloxifene is very similar to tamoxifen. The principal difference is that raloxifene does not activate estrogen receptors in the endometrium, so that does not actually pose the risk of uterine cancer. It still protects against breast cancer, and it can help improve osteoporosis, but it also causes hot flashes, and it also has the risk for thromboembolism. Raloxifene is the only SERM for prevention or treatment of osteoporosis and for prevention of breast cancer in high-risk women. The drug Duavie is from 2013, and it's conjugated estrogen/bazodoxifene. And this was developed for prevention of the vasomotor symptoms and osteoporosis in postmenopausal women with a uterus. Duavie is the first drug that combined estrogen with an estrogen agonist/antagonist. So the component of Duavie of the bazodoxifene reduces the risk for the excessive growth of the lining of the uterus that can occur with other compounds. But you still can have issues, and so any contraindications to estrogen still apply as a contraindication to this Duavie. Okay, next medication that could be given is progestins. So oftentimes progesterone and estrogen or estradiol are prescribed together, but let's go through progestin and just make sure we really understand what we're doing with that. Progesterone acts before gestation to prepare the uterus for implantation of a fertilized ovum. So in addition, progesterone is also necessary to help maintain the uterus throughout pregnancy. So when we talk about, if we go back to our slide here, progesterone has this sharp increase when we're hoping ovulation and pregnancy has occurred in here. And then if it doesn't happen, then the progesterone will have a sharp drop off. So during that, we don't want that sharp drop off. So once someone is pregnant, the progesterone level needs to stay fairly elevated to help maintain that uterus lining. Progesterone is produced by the ovaries and then the placenta during pregnancy. Ovarian production occurs during the second half of that menstrual cycle, like we just looked at. And during that time, progesterone is synthesized and created by the corpus luteum in response to the luteinizing hormone from our anterior pituitary. So if plantation of a fertilized ovum does not occur, no pregnancy happened, progesterone production by the corpus luteum ceases, like falls off quickly, and then the menstrual flow begins. However, if implantation then does take place and pregnancy has occurred, the developing trophoblast will produce its own luteotropic hormone, which is the HCG, human chorionic gonadotropin, that will stimulate the corpus luteum to continue making the progesterone. So where do we get the HCG from? That occurs because implantation has taken place, a fertilized egg has implanted and develops into the trophoblast, and that trophoblast actually produces its own luteotropic hormone, or HCG. For the first 7 weeks of gestation, the placenta depends entirely on progesterone from that corpus luteum. So sometimes in early pregnancy, when people have spotting, the female starts to spot, so we're early, 4 weeks, gestation 5 weeks, one of the medications they're given is progesterone. Because if we boost up the progesterone, we can decrease the bleeding of the endometrial lining. So that makes sense. And then once 7 to 10 weeks, the progesterone is shared between the corpus luteum and the placenta. The placenta can now start helping production of progesterone. After 10 weeks of pregnancy, progesterone made by the placenta is sufficient to support the pregnancy, and then ovarian progesterone production declines. So placental synthesis of the progesterone and estrogen will continue then throughout the pregnancy. So progesterone is very, very important in pregnancy and conception, especially during the implantation phase. So the mechanism of action is very similar to estrogen in a lot of ways. The receptors for our progesterone are found in the cell nucleus. Hence, to produce an effect, progesterone must diffuse across the cell membrane, migrate to the nucleus, and then be able to bind with the progesterone receptor. So remember, that's going to be a little bit slower of an effect than if it were able to have a receptor on the cell surface. The progesterone receptor and complex then binds with progesterone regulatory elements on the gene and rapidly increases gene transcription. Okay, just like the estrogen, we have an alpha and a beta progesterone receptor. So if you ever hear that, that's where that's coming from as well. So during the menstrual cycle, our progesterone is secreted during the second half of the menstrual cycle here into the luteal phase. If implantation does not occur, progesterone production obviously drops off, which is what triggers then the shedding of the lining of the uterus. It also affects the endometrium, but it also affects the endocervical glands, breasts, body temperature, respiration, and mood. Under the influence of progesterone, secretions from the endocervical glands become scant and viscous. In contrast, estrogen makes these secretions profuse and watery. So part of natural family planning for females can be actually monitoring their endovascular secretions, and whether or not they are profuse and watery or scant and viscous can be a clue as to where a woman's at in her ovulation. Also, progesterone causes the epithelium of the breast tissue to divide and grow. So female pregnancy has high levels of progesterone and the boobs do get bigger. The breast tissue will expand. However, it also has some actions in the CNS which can cause depression, but can cause fatigue, moodiness, and sleepiness. By increasing the sensitivity of our respiratory center to CO2, progesterone also causes partial pressure of carbon dioxide in the blood to fall. So at mid-cycle, when ovulation is occurring, progesterone will raise your body temperature by about 0.6. So if you've ever wondered why people are monitoring their body temperatures during trying to get pregnant, it's because of that reason. So when a female is not pregnant, progesterone levels do one thing. When you are pregnant, when a female is pregnant, the progesterone levels increase. These high levels suppress contraction of the uterine smooth muscle and help sustain the pregnancy. So remember, progesterone is vital for the healthy functioning of the placenta and the uterus. And when you have high enough levels of progesterone, you don't have smooth muscle contraction. Unfortunately, progesterone also suppresses contraction of the GI smooth muscle, which leads to prolonged transit time and constipation. In the breast, those higher levels of progesterone are what are needed to promote growth and proliferation of the alveolar tubules, acini, which are the structures that will produce the milk. Metabolic effects of the high levels of progesterone include suppression of the arterial PCO2, also can lead to altered serum bicarb, and can have an elevation of your serum pH. And then progesterone may help suppress your maternal immune system, thereby preventing immune attacks on the fetus. So that's a good thing that you have enough circulating levels of progesterone. Some women that have not been able to carry a pregnancy to term will have like supplemental progesterone given. Okay, so we talked about that, but let's talk about how we used the pharmacologic progesterones. When we use it for menopausal hormone therapy, the purpose of it is to counteract the adverse effects of the estrogen on the endometrium. One of the other reasons people are given progesterone is dysfunctional uterine bleeding, and that condition is characterized by heavy irregular menses, and that usually occurs when progesterone levels are insufficient to balance the stimulatory influence of estrogen on the endometrium. So in the absence, if you don't have enough sufficient progesterone, estrogen is not challenged, and it puts the endometrium in a state of continuous proliferation. Because progesterone is unavailable to induce monthly endometrial breakdown, the excessive proliferative endometrium undergoes spontaneous sloughing at very irregular intervals or for prolonged intervals. So treatment with progesterone for dysfunctional uterine bleeding has two objectives. The first is obviously to have the patient stop bleeding, but the long-term goal is then to try to establish a regular monthly cycle. Excessive bleeding can be stopped by administering progestin for 10 to 14 days, but then when the dosing is stopped, withdrawal bleeding will likely take place. That bleeding is likely to be profuse and associated with really bad cramping. So most women in these situations are given an oral contraceptive twice daily for 5 to 7 days to stabilize the endometrium and reduce bleeding duration. And then they typically start some kind of cyclic therapy. Progesterone also can be given to women if they have no menstrual flow. So if that's called amenorrhea. So if you have endogenous estrogen levels that are adequate, treatment with the progestin for 5 to 10 days will be followed by withdrawal bleeding when the progesterone is stopped. So you can induce a menstrual cycle. You can also use it for endometrial hyperplasia and endometrial cancer. Progestins can provide palliative type support in women with metastatic endometrial carcinoma. They don't necessarily prolong life though. And those things are obviously managed by a specialist. Also possible is that, like I said before, we give progesterone to early pregnancy when women with corpus luteum deficiency syndrome or people on IVF. So those things to help kind of stimulate and keep up and support the pregnancy. All right, just like estrogen, progesterone has the possibility for adverse effects. 20% of patients on this drug will experience breast tenderness, headache, abdominal discomfort, kind of body aches, and depression is a possibility. When it's used in the form of birth control, it can greatly decrease the production of your cervical mucus and cause involution of the endometrial layers, which can then also lead to spotting, breakthrough bleeding, or irregular menses. And progestins, in combination with estrogen, increase the risk for breast cancer in postmenopausal women. All right, route of administration, oral, IM, sub-Q, intravaginal, intrauterine, and transdermal all are there. The intramuscular progestins are like Depo-Provera, like we've heard of before. We'll talk about that more in the next chapter. Same thing for key prescribing considerations for your progestins. You want your basic metabolic data, blood pressure, weight, pregnancy test, and then a good screening as well. Next option then is we use drugs with combinations of these as hormone replacement therapy. So menopausal hormone therapy often is again called HRT, hormone replacement therapy, and that typically consists of a low dose of estrogen with or without progesterone. So a low dose of estrogen taken to compensate for your total loss of estrogen that occurs during menopause. So we have the options of two different ways to do hormone therapy: estrogen alone, which is estrogen therapy ET, or EPT, which is estrogen plus a progestin therapy. Having estrogen in both regimens, remember, is to control the menopausal symptoms by giving exogenous estrogen that you have lost. The progesterone is present for one reason only, and that is to counterbalance the estrogen-mediated stimulation of the endometrium to help reduce endometrial hyperplasia or cancer. Progestins should not be prescribed to anybody who's undergone a hysterectomy because they don't have a uterus anymore, and there's pointless to give progesterone. The most driving force that women seek hormone replacement therapy is the vasomotor symptoms. The hot flashes and the drenching sweats can interfere with daily living, cause those horrible sleepless nights. They're uncomfortable, they can be embarrassing. I mean, these are situations where women are like all of a sudden, quote unquote, pitting out at work. They're drenched. Like you look over and people look at them and go, "Are you okay?" And they're wringing with sweat. Their hair is curly because it's so wet from sweat. So people don't like them. They don't feel good and they can be really embarrassing. So some women will tell you that hormone replacement therapy is life-changing because it could help manage those symptoms. Women who take hormone therapy oftentimes do report an improved quality of life, but they also tend to have improved sleep, improved libido, improved cognition, and a better mood. Those are all good things. From a medical perspective, there's 3 benefits to hormone therapy though. 1, suppression of the vasomotor symptoms. 2, prevention of the urogenital atrophy. And 3, prevention of osteoporosis and osteoporosis-related fractures. For those purposes, it is also highly effective. The trouble is that once you have to withdraw hormone therapy, the benefits of like the urogenital atrophy and osteoporosis don't sustain, and it's withdrawn, and then you're back at the risk for those. Given the positive physiologic effects of the estrogen and the detrimental physiologic changes that occur with its loss, it seems logical, like why wouldn't we put every female on hormone therapy? This was common practice a long time ago. Many women just automatically were given hormone therapy. And then we had 2 kind of revolutionary studies done in the early 2000s. The one was called the Women's Health Initiative, WHI, and then we had the Heart and Estrogen Progestin Replacement Study and its follow-up, which were called HERS and HERS2. And those studies clearly demonstrated that, contrary to the popular belief, hormone therapy could increase rather than prevent cardiovascular events. So we knew that having estrogen naturally endogenous was cardioprotective in a lot of ways. So the assumption was if we gave it exogenous, we would get this great cardiovascular prevention and decrease, and that's just not true. Women that were taking hormone therapy in the study had an increase in thromboembolic events such as DVT and stroke. For women that were receiving EPT, so they had the estrogen and progesterone therapy, there was a significant risk in the incidence of breast cancer. The reaction in the medical community was strong and swift, and many providers stopped prescribing it altogether. Like I've said before in other videos, the pendulum swung. We started giving it to everybody, so the pendulum swung to the left, and then we realized that was too far. So instead of just bringing the pendulum back to the middle, it swung all the way to the right, and then people became terrified to give anybody hormone therapy. Then the medical community got smart and said they started to scrutinize those studies and really break them down. And what they found really was that we had to take into consideration how the studies were done. The subjects in those studies tended to be older, so only 3.5% of the women in the WHI study were in the 50 to 54 year range, which is the most common age for hormone therapy. So that was interesting. And the hormone therapy given at those studies were higher doses and prolonged doses. So we realized that if we can give smaller doses for shorter periods of time, they're probably pretty safe, or safer anyway. When the WHI data for women aged 50 to 59 taking hormone therapy for less than 10 years was examined, it was actually discovered that the increase in the venous thromboembolic episodes was only between 1.1 to 5 out of 1,000 women. So when the benefits were really examined for both estrogen therapy and estrogen/progestin therapy, 5.1 to 10 out of the 1,000 women experienced a reduction in overall mortality compared with women not taking the HT. So subsequent and still ongoing research has provided more insight into this. And so there's a more, I think the pendulum's finally coming back down to the middle. And again, it's saying we have to have a good risk versus benefit discussion of hormone therapy. So that is really taking into account the risks of cardiovascular disease, how bad their symptoms are, what they're willing to do, that they have good follow-up, what those risk versus benefits are, and then really close monitoring and a good relationship with your provider is really what is at the key here for having good options for hormone replacement therapy. So it's come back into favor, if that's the right word. It's used again. You still will see it, but you have to understand there's a risk benefit there. That's why I'm saying that you have to reassess. If the female that comes to you and their primary issue is the vaginal dryness, and you start giving them some form of estrogen and it doesn't help, don't keep them on it. Because it's not worth the risks then of using estrogen. But there are women that take estrogen replacement therapy, hormone therapy, and if you tried to take it away from them, they'd probably pull out a butter knife, right? Because it helps them so much and improves their quality of life that to them the risk is worth the benefit of the medication. However, generally speaking, women older than 60 that take higher doses, long-term hormone therapy for more than a decade could not be generalized to the younger women taking low dose for shorter periods of time. That's what we finally came to believe. There's a ton of studies going on right now to really investigate the safety of low doses in younger people. And I think this is something we're going to continue to see evolve for many years. The table 50.1 breaks it down into the numbers for you of the benefit over 5 years. So based on the findings that are in that table, the book talks about, especially considering the benefits of overall mortality, it seems unreasonable to refuse hormone therapy for younger women desiring it once individual risks are assessed. So there you go. And the general idea is that your risk is going to increase with age. A 50-year-old versus a 65-year-old, two completely different risk factors just based on their age alone. Also, what there is, the thought process is that over the age of 65, estrogen hormone therapy actually increases your risk for dementia. So definitely not indicated in that range. The book also provides you this lovely little figure 50.2 with this additional guidance of what you could say from the Endocrine Society, the FDA, and the U.S. Preventative Services Task Force regarding the use of hormone therapy. The yes and no's, and kind of tells you an algorithm you could follow. The general recommendations of this is that for most women, the benefits of long-term hormone therapy for disease prevention do not outweigh the risks. So long-term hormone therapy should be avoided. They define long-term as greater than 5 years. But conversely, the benefits of short-term, less than 5 years, to treat menopausal symptoms often do justify the risks. So to keep the risk as low as possible, it should be used in the lowest dose and for the shortest amount of time needed. The 3 indications for approved use of hormone therapy with estrogen is treatment of moderate to severe vasomotor symptoms with menopause, treatment of the genitourinary syndrome of menopause, or prevention of postmenopausal osteoporosis. For the first 2 of those, the duration of treatment is relatively short. It's typically 3 to 4 years or less, and so the risk for harm is relatively low unless they already have significant risk or have heart disease. In contrast, prevention of osteoporosis requires lifelong hormone therapy, and then the risk becomes higher. Remember, EPT, estrogen progesterone combo, should only be used if they have an intact uterus. The other important thing about options for treatment of menopausal women, there are some drugs out there that also may help that are not hormone therapy. Hormone therapy is the most effective for the vasomotor symptoms. However, if you're at too high risk or they don't want to go down that route, 2 of the antidepressants, which is escitalopram, Lexapro, and desvenlafaxine, which is Pristiq, can produce a modest, meaningful reduction in the frequency and severity of hot flashes. Escitalopram is an SSRI and the desvenlafaxine is an SNRI. They also have paroxetine, was approved in 2013 for the symptoms as well. Some people have used clonidine with effect, and some people have used pregabalin with a moderate effect to help reduce symptoms. However, we've also done controlled trials on those soy isoflavones, and they do not reduce hot flashes. Also, black cohosh, once commonly recommended, has fallen out of favor and has significant risk for harm. When you're talking about the genitourinary syndrome of menopause, estrogen's the most effective by far and away, but it also has those risks that we talked about that way. Remember that the FEM ring was that second ring we talked about, and that one does have enough estrogen to cause the systemic effects, which is why it can be used for vasomotor. The first ring we talked about does not. Prevention of osteoporosis specifically, whenever you stop the hormone therapy, bone mass rapidly decreases again. So if you really want to use it, hormone therapy would be continued lifelong, but there's such an increased risk for that. And so hormone therapy has to have those risk factor statements on it about not being on it forever. Inappropriate uses. You do not use it for the prevention of heart disease. That's a long dispelled wrong way of thinking. And you do not use it to prevent dementia. Discontinuing the hormone therapy, yes, you can definitely have a recurrence of your symptoms within 4 days of your last hormone therapy dose. So there's no firm guidelines on how to stop it, but there are basic methods. You can either immediately cold turkey quit it, or you can taper slowly. For women that choose to taper, they can do dose tapering or day tapering. And I do find that has been pretty well tolerated by people. But the problem is that if they're on a combo estrogen-progesterone therapy, the progestin should not change, and it's only the estrogen that would change, so that could be tricky for some. All right, then we get down to the big thing to remember too. Estrogen therapy has a black box warning. Endometrial cancer risk is increased with women with a uterus who take unopposed estrogen. Estrogen can increase your risk for DVT or stroke. And estrogen is not indicated for cardiovascular disease or dementia and shouldn't be given to 65 and older. Black box warning is also present for estrogen and progesterone therapy. Pretty much the same exact thing, except that estrogen plus progesterone may increase breast cancer risk. Okay, and then there is estrogen that is used for drug therapy for transgender. And the book goes into that discussion there and whether or not they have their testes and all of those things. Management is highly individualized. This is something that is going to be handled by a transgender specialist that's going to know how to monitor this and how to do this, because now you're balancing your natural producing testosterone counterbalanced by your estrogen and all of those things. So the big thing about this group of people is that you have to make sure you're still being safe with their risk factors and understanding what you're doing with the manipulation of the hormones and what you may be protecting them from or depriving them from when it's talked about from a hormone perspective. And you don't have to worry about the drugs for the female sexual interest arousal disorder for the quizzes or tests. Okay, that wraps up the first part here, and next we'll get into chapter 51. Thank you.